We're going to get started with this next panel, and I know that you're all used to seeing me at the podium, but I'm going to actually take a seat right now and serve as the moderator for our next panel on hardware and healthcare. I think a lot of folks here know me in my role at HardwareCon. What you may not know is that I've been a serial entrepreneur in my career, and I spent about the last 5 years involved in helping to start healthcare companies and really looking at how technology can innovate in the field of healthcare. This is a multi-trillion-dollar-a-year industry, and I think we all can agree that there's been a lot of movement and that it really needs to be fixed. So I'm super pleased to have a panel of experts that are joining me today, and I'll talk a little bit about who we have here, but really just as a kind of a lay of the land. You know, one of the things that we've seen is a lot more technology getting involved in healthcare. We see it's not only traditional medical device and pharmaceutical companies, but Apple is actually now having meetings with the FDA. Clearly IBM with Watson is getting involved. Microsoft, Google actually kind of famously spinning off its healthcare division as Verily. And so there's a lot of tech companies that are really looking to innovate and disrupt in this space. So I've put together a panel of folks that actually come at this area from a number of different angles. One person that's actually still on her way here, had some car trouble, is the CEO of iSono. It's a medical device company. Mariam Zaei is a PhD computer scientist from Stanford, has been involved in creating medical devices and sensors really throughout her career, and recently took the plunge to become a first-time CEO with iSono. She'll be here with us in a moment. I'm going to let these ladies introduce themselves, but just really quickly, Geeth Rao, who was actually here with us last year at HardwareCon, and by popular demand, we've got her to come back. Geeta is just brilliant in the space of medical devices, and like I said, I'll let her explain, but I was so impressed with her last year that I brought her into work at my company, Pear Therapeutics. And Mary, I'm blanking on your last name. Mary Vincent, I was going to say Smith. Mary Vincent is likewise a serial entrepreneur who began her career at Sun Microsystems when I was at Silicon Graphics, so we had a little competition back in the day. And now it's all about collaboration. But let me start by actually, Geeta, why don't you give a better introduction of yourself?
Oh, thank you. It's a real pleasure to be here again this year. So my background is initially as an engineer and as a technologist, and then eventually went to business school, went over to the dark side for a little bit, but really still pretty grounded in technology and a lot of hardware technologies. So a lot of my work is around commercializing early stage technologies, especially those with a very heavy science or technology component that's largely still in academia. So what Beth was referring to from last year was this notion that when you're in a regulated space like healthcare, there's a popular misconception that healthcare is regulated but the technology gets regulated by healthcare, and that's not really true. It's the intended use or the claim that you make that gets regulated, and therefore your market strategy is your regulatory strategy. So in some sense, when I'm working with commercialization, a large part of what I do is figure out what the regulatory strategy is, and then since I also work on that question from the other side of the table, I also support the FDA, either directly or indirectly, through various committees of standards organization, and the FDA directly. I've been a consultant directly to the FDA and still work with them on how they should be regulating emerging technologies. That gives me a sort of a chance to bring the Silicon Valley interest to the table over there. So I work on both sides. And then the third piece is often with academia, trying to get early stage science or technology positioned for the market with the right perspective. So all three aspects of it.
Great. Mary?
Thanks, Beth. As Beth mentioned, I was at Sun Microsystems Java Engineering, and we were the IT systems group for Java. So we were developing the CRM systems, not only for Java engineers, but for finance, legal, marketing, and they were accessing our systems. So I was there for about 8 years, and I wanted to do a startup. but it had to be a startup that meant something. And I saw Sun was doing a lot of work in data center energy efficiency and selling a lot of servers there. And so I said, I wanted to do something relating to climate change and reducing energy use in IT environments, and Sun was already doing that. So I said, okay, I can learn hardware and data centers. And so I left Sun to do data center energy efficiency. Pretty much soon after that, I got asked to advise Stanford Engineering for Good class, and they were doing mobile health apps for the government of Bhutan. And they said, Mary, do you want to run this project? So working with Ministry of Health, Ministry of IT, Stanford students that were managing the UX, and then also the engineers. And I said, of course. So I did all that management, and I also established a stakeholder team with the head of telemedicine for the country and demoed the apps to the Secretary of Health and the Prime Minister. So I got that project approved in one region of the country for a pilot. So I came back here, and somebody said, a friend is doing a wearable startup. And they need somebody that understands mobile health applications, but also the startup world. And they were doing smart fabrics, and they needed a CTO. And so I said, sure. So I learned all about materials, conductive materials, and how it integrates with the sensors, heart rate variability, the iOS app, hired the first data scientist that had an expertise in heart rate variability onto the team. And so that's kind of where my health tech started. So while I was pitching in a hardware incubator for this smart fabric startup, SK Telecom just started their venture firm. SK Telecom is out of Korea. They have an accelerator that invests up to $1 million in seed stage startups and a VC fund for Series A through Series B investments. So they asked me to pitch to them. That's where I got a chance to learn more about the team. And they said, Mary, we need somebody that understands materials, because they invest in materials, data centers, because they invest, but also health tech. And so I've been at SK Telecom as an EIR for about 2 years now. And then I also advise a California Life Sciences incubator. So I see a lot of imaging startups, biotech, and I advise a genomics company in China. So there is a convergence, between medical devices, genomics, AI. So I pay attention to that space as well.
Very cool. You use the word convergence, and I think that's one of the things that we're really seeing kind of come together in the past year or so. And it's actually kind of interesting that we have 3 folks up here talking about healthcare, engineers and MBAs and the like, and no clinicians. And I think that's really interesting because, as I mentioned, Apple, IBM, Microsoft, everybody's really interested in healthcare these days. Because of this convergence that's happening. So I'd really like to kind of talk about, our philosophical approach to this convergence, how we see things moving, how we can really be disruptive/innovative in healthcare. Geeth, you want to start?
Sure. So I, way back when I first started looking at this space a number of years ago, there were some very, very clear spaces. There were different spaces. So there was sort of if I can, go down. So first there was sort of the enterprise space, which is what the hospital did. And there was some data systems, EMRs had already been put in place. People were just starting to explore. It was beyond just billing and risk management. They were starting to see if they could use EMRs in proactive patient care. So there was that whole data EMR space. Then there was sort of the big machine space, the MRI machines, the X-ray machines, the CT scanners, and various big surgical robots, and sort of capital equipment space. And definitely kind of hardware was centered around that space. And that didn't in any way talk to the data layer above it, or that managed it. And then there was sort of a separate space, which was the workflow productivity space, the nurses stations, the call centers, the patient data management spaces. And then something we didn't even think about in terms of healthcare technology was the consumer space, the patient space, and possibly even a thin layer in the middle of the community advocacy or the activist group spaces. What's happened now in the theme of convergence is there is no technology that exists in one of these spaces alone. Everything touches everything else. in some fashion. So if you're an entrepreneur, you really do need to map out your strategy in terms of the entire healthcare ecosystem. You know, it's not just what the patient wants, it's what the caregiver wants, it's what the nurses and the care coordinators are looking for, the clinical staff's looking for, the specialists, the facilities, the providers, the researchers. And typically when I look at sort of the stakeholder map, there's a minimum of 10 classes of stakeholders that you should be looking at. So this sort of impact on technology is that we've got to very quickly learn a lot about a lot of different aspects, you know, not just the technology.
Yeah, so excellent. Relating to integration, yes, that's of course very key, but also as an entrepreneur or on the VC side, looking at what the problem is. And so I saw that in a lot of the spaces that I've worked in. So for example, when I was in Bhutan, we were putting a standard treatment guideline and essential drugs list onto an Android tablet. But while I was showing a senior medical doctor for the country, she said, you know what, we're starting this new regulation for the country, non-communicable disease spreadsheet, because folks at 40 and over were starting to get heart disease, diabetes, et cetera, et cetera. So they wanted to screen these folks in the clinics. And she said to me, can you create an app for me? You know, basically doing what you're doing. And I said, sure. So I contacted our engineer, and he said, yeah, I'll do it tomorrow. And then we got it done the next day, and I showed it to her, and she goes, oh my gosh, you could like move very quickly. So, but to understand their needs, you know, from a regulatory perspective, because that was a new mandate for the government, but making it happen very quickly, like it was very key. Another thing that I've seen is, of course, everybody knows about the chronic disease problems on diabetes and cardiac, but also aging population. So a lot of people are going to live with chronic disease for quite a while. So there are a lot of hospitals, not only in the US, but in China, because I go to China a lot, and they're trying to figure out how to address the aging population. A lot of people are not able to go to a clinic. So how do you remotely monitor these folks or catch things early so there isn't an event? Medical doctors here say, I don't want to see you in the ER. You know, I want to know ahead of time, you know, and predict what potentially could happen. So Philips is one company that has been doing a lot of community care monitoring. So taking a cardiac patient that had an incident at a hospital, and normally when they come home, there's a good chance that there could be another incident. So they wanted to stop that, and so what they did is they started empowering the patient with their own vital data. So taking an iPad app and showing what their heart rate is, how long they've been sitting, how long they've been walking, what their pulse oximetry is, having recipes, videos, but also having them contact their doctor or caregivers or care team on a regular basis. So basically, because of this ecosystem being set up with IoT, with the doctor, the family, there was a 45% decrease in deaths, you know, for something like this. So like I said, looking at, you know, the whole ecosystem and seeing how you can address a problem. And that's a good example on what Philips has done.
You know, I think that's really interesting. And you know, when I really asked the question about convergence, I was actually coming at it from a perspective of, here we have these, you know, really different industries, right? Like Apple getting into the healthcare business. But what we've heard, and this is actually really interesting, and this actually even goes back to something we heard this morning when you and Thompson and Lisa Sunan were on the stage, is that there's this blending of this ecosystem, right? And we're actually kind of shifting even the way that we approach healthcare, because now we have to, right? It's, you know, it's no longer enough to just have one point of contact, you know, and there are multiple different markets out there that we have to, you know, kind of speak to. I want to go back to something that actually Ewan said this morning too. For those of you that were here, Ewan Thomas runs, for those of you that weren't here, You and Thomas now runs R&D for medical devices for Johnson & Johnson, has spent his entire career in the healthcare industry, and he was saying that there's this new model of, going directly to the patient and having that be the first point of contact. And to something that you were just saying, how do you engage that patient with actionable and immediate data so that the patient helps themselves? And so I would love to actually, explore this a little bit with, the companies that you work with, and Geeta, I know that you've got a number of companies that you're working with. How are people doing this and really effectively tapping into that direct-to-patient communication?
Right. You want to go? Okay. So something Ewan said this morning, which it behooves everyone in healthcare to remind ourselves of, which is that it's all about the patient. It's always about the patient. It'll always be about the patient. So, and something that's confusing for those people who are not in the healthcare industry is that the patient is not the customer. There is no singular customer in this industry. So, for example, the person who uses your device could be a surgeon or a physician. The person who benefits from the device is the patient. The person who pays for the device is the insurance company. And the person or the party that makes the buying decision, however, could well be the hospital. And there are 4 different stakeholders right there in your customer value chain. And understanding this it's easy to take your eye off the patient because that's not the person writing the check. And nor is that person even making the decision to use your device a lot of times. So what Ewan was talking about is the fact that traditionally medical device companies have come from either if it's like a personal tool, like a surgical tool, from the specialist, from the physician's point of view, or from the facility point of view, okay? They've rarely seen the patient as the direct or most immediate stakeholder. But that is changing with the convergence of technology also. And what's happening because of that is medical device companies have to move to becoming consumer-focusing companies. Consumer-focused companies are starting to see that they actually have an edge in this space, something that they didn't used to. They didn't know how to sell to the radiology department, to buy their $100,000 or $200,000 capital equipment, or $1 million capital equipment every year or every 5 years. But what they do know is how to reach, like Apple does, how to reach individual customers. And so it's sort of the technology convergence has both opened up markets in healthcare for non-traditional non-healthcare companies, and healthcare companies have had to move into non-healthcare spaces such as consumer engagement, good outreach tools, and something Mary talked about, and I'll let you elaborate on more, the involvement of communities of care now. It's not just a singular customer anymore. Even the patient isn't just a patient. It's now a patient surrounded by a care community. So that's very much a part of the landscape now.
Yeah, so I agree with everything you're saying. So there is this convergence on data in addition to Apple Watch and the patient. There are tests with breast cancer patients right now because when you're undergoing breast cancer treatment, you don't want to be under high stress. And the doctors want to see how a medication or radiation or anything else that they're being treated with is affecting their vitals. So if they're seeing an anomaly, they can intervene early. And so those tests are happening now with breast cancer patients. There's also a diabetes test that's going on. It's a Validic partnership. So Validic is basically a data warehouse of wearable data. And Sutter Health is one of their partners. And so Sutter, Validic, the US government has partnered on this diabetes management tracking system. And so that's another example of convergence because you don't want a diabetes patient not taking their medication, or you want to intervene early before something bad happens. So a lot of great things are happening right now.
So we've heard through the last 2 days, a lot about big data, a lot about privacy issues. It was actually interesting that people were calling it out as a red herring this morning.
Yep.
And I think that that's really interesting. And it was also kind of called out in another one of the panels that this tracking of objective data points is something that we're going to see. So I would love to chat a little bit about your perspectives on both privacy and big data.
Okay, so the two go hand in hand, and I completely agree with what both Lisa Swennen and Ian Thompson said this morning. It is a red herring in the healthcare space, let me be clear. It's in the healthcare space, and I can't tell you how many times it's come up in conversation, and patients, or more importantly, the caregivers for the patients will say, I don't really care about privacy if someone is going to help me. If this data is going to get a cure for my child, or if the data is going to help me manage my condition better, I'm all for sharing it. I don't really care.
The CEO of Patients Like Me told me at JP Morgan that people will share anything with anyone except their Facebook friends.
Correct.
Right? Because Facebook is this platform of where we want to sing the best.
That's right.
And Patients Like Me is they'll just tell everything else.
That's right. That's right. Or there are other platforms where they'll join groups, so they'll have an avatar in some forum somewhere. So there are mechanisms for people who are a little bit who have any concerns about sharing their true identity, but they don't have any concern about sharing the data, largely. Right. Now, Lisa did talk about the hackers who are going to turn around and sell it. As long as there are protections in place, and we're hoping they can be improved, in terms of anti-discrimination or anything else, people's vulnerabilities are not, your healthcare data is by far, the least of it all. However, we do have regulation around HIPAA in particular, and the regulation came in at a time when before the Affordable Care Act, and there was this very close linking with, and still remains a large link between employment and healthcare. And therefore this concern about discrimination in employment is what's kind of driven some of that HIPAA regulation. I think people are starting to realize that if you can separate the data from the two, or you make it illegal for an employer to discriminate, and in particular, there were two concerns. One was the employer, but probably even bigger concern was pre-existing condition discrimination. And now that's been outlawed. That definitely makes a big difference. Right. So people people want to have that data be out there because they want their doctors to know about it. But if in the meanwhile you were scared that your data would get used to discriminate against you in your insurance dealings, then that becomes a concern. So now I think we're easing up some of that. So I don't think that's a big issue. The big data part, I think, is really fascinating still. I think the big data, I think there's some open ethics and public policy questions that are still not resolved in there. So one of them is who owns this data. Right. If you as a patient own this data, how can you make sure that if it is monetized by somebody, it's appropriately monetized, or you're reimbursed, or that if you don't want it monetized, you're allowed to do that. Unfortunately, the Senate just passed a bill last week that reduces that privacy, or your right to your data. Right. So and healthcare is probably one of the biggest application areas for big data over there. So I think those are issues that as a society we have to figure out. I don't think it's privacy directly, it's the opposite now. It's not privacy, it's your right to own your data and sell it so you benefit from it. That's what's going to be that's really great. And Mary, prior to, rather than going a little bit more into the privacy, because something that you were saying and talking about monetization brings to mind, and we've already heard today, all of the friction points that are in the healthcare ecosystem. There are multiple classes of stakeholders. We talk about at Pear and some of the other companies that I work with, multiple levels where you have to, measure efficacy, right? There's got to be
clinical efficacy, there's got to be payer efficacy, it's got to have endpoints, there's got to be workflow efficacy for the clinicians, and it's got to be efficacious for the patients. The patients have to take the medicine, right? And now you're talking about monetization, and this is really interesting. And so a room of entrepreneurs here. Let's talk a little bit about business models that we see in the hardware and healthcare space.
Oh, yeah, I was going to talk about privacy and security. Do you mind if I mention that before going into business models? Because when I first started getting asked to talk about IoT globally to hardware manufacturers and developers everywhere, so in Shenzhen, Dubai, Google Developer Group, nobody was talking about privacy and security 2 years ago. And I'm like, no, you need to talk about this. So for those of you who are creating hardware, firmware, or using devices, these are the recommendations very quickly. So for wearable security, change your default passwords, turn Bluetooth off when not required, limit amount of information to what's required, read and understand privacy policies, mobile device security, PIN or password protect your device, be mindful of permissions, turn non-essential antennas off, that means Bluetooth, for example. Stay with trusted app stores, because in China there are many Android app stores. Cloud service security. So when we're talking about HIPAA compliance, we know that Amazon Web Services and Microsoft are HIPAA compliant, so stay with those cloud services. Use multi-factor authentication. Only collect data necessary to deliver the service. Require strong passwords. Implement secure session management. So for me, when I create hardware, I don't want all this information about you. I don't want to be subpoenaed by a government agency to get this data about you that's very personal. So for hardware providers, creators, make sure that you keep these things in mind. And there's something that the FTC just recently placed on their website to make sure that you're abiding by the laws for the Federal Trade Commission, FDA, and Office of Civil Rights, which I didn't know about until recently, OCR.
Yeah.
So it's a checklist when you're developing any mobile device to make sure you're HIPAA compliant and you abide by all these regulations. So just go to the FTC site and then Google Mobile Health App Interactive Tool.
So Mary's actually just really cementing my point that there's lots of friction if you want to create a medical device company.
Right.
And I think a big thing that I say when I'm and I advise through the Plug and Play and Launchpad Digital Health, and I have other companies that I advise. It's this idea around, okay, so if you've been able to beat through all of the friction points, and including all of these regulatory points, what kind of business model is going to work?
Yeah. So, with all due respect to all the entrepreneurs here, pretty much every IoT company thinks they're going to be the tail that wags the dog, right? Oh, we're going to have this data, but then we're going to collect all this data around it, and then we're somehow going to monetize it all. I mean, it's kind of in a nutshell, that's what everyone's thinking. And in fact, this morning, Ewan said something along those lines, is that you have to be thinking like that. And his kind of, what he framed as his realization that, a single class of data acting in isolation isn't that useful. It doesn't mean you have to collect all the data yourself, but you have to play in this playground of data. There are other people who are collecting data. The companies like Validic, their business model is built on data aggregation, and they've done a really nice job of creating kind of a fast track through the regulatory process there. You go through their process, it's very accessible, and then boom, you're through it, and you're part of their app formulary or whatever they call it now. And there are other app formulary companies, both private and public, like Validic. So I think it's creating, I think that the business model is not unlike other new technologies where there is a model for the core hardware company that's making the hardware, the sensor or the point of use device. There is a model for the data transmission and cloud management, the telcos and the hubs, and they could also have a hardware component like Qualcomm had the 2D device or the 2net device and so on. There's a business model for the data aggregators. There's a business model for just the AI portion, the algorithms people. They don't have to have any part of even collecting the data. They just need to have tools for creating intelligence out of, or insight out of data. And then you have the tools for the clinicians, the business model for the clinicians that are providing the care. So I think in some sense, any given company needs to think about, and something the last panel talked about, who are your channel partners? You're no longer just a single company and that owns the entire value chain. You really must understand your place in the value chain and how much of the value chain around you do you want to capture yourself and how much do you want to partner with others. And you really have to kind of get clarity around that. And we can talk at some length about what are some successful models, but right now it's sort of in the gold rush, the people who sold the tools and Levi's made the most money. It wasn't the miners. Right. Okay, so if you're the point of use device, you're more like that gold miner. If you get lucky, yes. But largely, if you're the tool provider, you're probably in a stronger, you have lower business risk at this point. It's less fun, but it's,
I agree completely. And this really goes back to what you were originally saying, that there are all of these stakeholders, and our approach at Pear is to not disintermediate the clinicians, to not disintermediate the other devices, and you've got to really work and play well with everybody. And Mary, now I know you advise a number of healthcare startups. What are you seeing out there as the best approach to a business model?
Yeah, so amazing data explanation, because it is complex, but data is where money is at. So I really love that. So for the other startups that I advise or I'm involved with, so there is one that is a conductive ink startup. They're called Electron Inks. They have particle-free ink that is used in OLED displays now. They were in Project Aura. They're moving into wearables. That you can easily integrate this ink into fiber or textile. So if you're using smart fabrics, it's great. It's highly conductive. So there are ways that you can look at licensing this product or having your own product. So there are a lot of different models. So B2B, B2C, which is pretty lucrative, I think, right now, because smart fabrics are becoming a bigger market than it was just a few years ago. If you're looking at cartridge models, which is pretty much what the biotech industry kinds of uses. So there's a company out there called Life Bioscience, and they're trying to detect MRSA in hospitals. And so these cartridges, have one detection system for MRSA, one for C. difficile, and one for others. And so that's the way they make their money, is because of that cartridge system. So those are two examples.
So I want to introduce Miriam Zaidi. And Miriam, we were just talking about business models around healthcare. And while you catch your breath, I want to talk about how we've actually kind of approached this at Pear Therapeutics. As I said, we really don't disintermediate, and not only with Pear, right? So we're looking to get right into the value chain. And so for anybody out there that has a startup where you're looking, there's really two ways to do that. One is like a health economic model where you're decreasing costs or improving outcomes, and the other is a productivity model, where you're working directly into the healthcare chain. Now, of course, there are multiple different models where you're going direct to consumer, but getting consumers to part with any dollars around healthcare is very challenging. Yeah. And you take your total addressable market and you shrink it completely. So, Miriam, why don't you give us a little overview of your iSono, and what is your business model, and how are you approaching the market?
Sure. Hi, everyone. Sorry being late, a little bit of a accident. iSono Health's mission is to make breast cancer screening accessible to all women. And we've done that. Our platform essentially combines an automated ultrasound, that's the hardware part, and we combine that with machine learning and deep learning to enable more personalized monitoring over time. So that's the accessibility comes from the automation of the ultrasound, and the better results essentially comes from adding a layer of analytics and data to that. And our business model right now is essentially B2B2C. So our goal is to start there, and as you said, then maybe eventually move to consumers. We started, as we've talked to Geeth about this, is that we started saying like, we want to go direct to consumer, and we quickly realized that it's going to be challenging. It's going to be the reimbursement path is very hard, and as a startup, you really are an unproven entity, so it's hard. So we said, well, why don't we, prove it in, sort of a low-resource clinic settings, and we're going also the corporate wellness and corporate clinics route, and then while you have that model, then it becomes, it's a different strategy. You become available to public, for consumers. So.
Great, thank you.
Can I follow up on that a little bit?
Yeah.
So I think it depends on the clinical condition a little bit. So there's some conditions like cancer where I think cancer patients are very actively involved in managing their cancers. So they are very motivated, and it can be a true partnership between the clinician and the patient. So that lends itself to the kind of business model Miriam was talking about. There are certain conditions, in particular congestive heart failure or even diabetes, where people don't want to spend their lives thinking of themselves as a person with a disease or a sick person, as Lisa called it this morning. So in those cases, the less patient involvement there is, or the more passive the patient needs to be, the better off you are, because they're much more likely to be involved. And the active management comes from the clinician. And then there are those that are more, let's say, wellness or fitness-oriented clinical situations, there's a couple of exceptions to that, and one of them is pediatrics. If a parent is responsible for a child's health condition, they're very much motivated to own it themselves. Then in those cases, the direct-to-consumer works really well. So if you have, for example, a device for like an EpiPen, or something that's point of use, or an asthma tracker, or something that a parent is, or a pediatric tracker of any sort, then you're going to see a direct-to-consumer model work out. So the business models, I think, break out by clinical condition to some extent, and they also break out by if it's a primary care physician that can deliver this care, they are overworked, and they are very happy for the patient to own more of it. If it's a specialist, you described this morning at a LifeCore, the cardiologist doesn't want, reams of ECG popping up in their emails. They are not as receptive to patient involvement. So it's really it breaks out based on what the condition is and the caregiver, the clinician type.
I agree. And it is etiology based,
yes.
and it's also kind of a workflow issue, and you're absolutely spot on that the internist and family practice docs are just like so overwhelmed.
Yeah, they're happy for you to come in with a nice chart and say, look, here's my diabetes, or here's my track of my whatever condition it is you're watching. Yeah.
And here's what I'm doing. I want to invite the audience, if you have questions for our panel, to please come on up. I want to make sure that we leave a little bit of time for you all to engage. Okay, well, go ahead.
Thank you. Hi, I'm Jesper. I'm with a biotech company which is in the B2C space. So we sell a sperm tracker, which you can use to take control of your male reproductive health. And the thing I'm seeing is a bit of a tension in respect to the different stakeholders there are, that the value proposition for the medical community is different from what it is to the consumer. So how can you deal with that tension that is there? What would you advise on that?
It's interesting. It's the third company in that space that just this week I happened to coincidentally look at. So I think I want to actually answer that question somewhat indirectly based on something Beth had said earlier. Beth, you had talked about wanting to be integrated into and not disrupt the clinical space. Sperm tracking is perhaps one of those spaces where there is an exception to that rule. And it is where there's a perception of either this is discretionary care, or it's not covered, or you have something with a very high deductible, a kind of a plan or coverage that involves a high deductible, where the patient has to own the early part of the care cycle. In that, and infertility is one of those, right? Because to go through fertility treatment is a very expensive proposition. But before you get there, for a lot of people, it's not one day you go into the clinic and you're declared infertile. It's an evolving or an emergent condition. So situations like that, I think there is a different, you have the patient-owned space or the patient-owned part of the trajectory, and then you snap into the physician-owned part of the trajectory. And in some sense, in your case, I would say that the two are actually distinct phases, and you have to decide whether your product's patient-facing and how early you want to capture the patient. You know, do you want it to be something that they start thinking about as soon as they turn, 30 or whatever age you think is a magic age they should be starting to look at, or certain high-risk professions or whatever? Or do you want to actually move it further downstream where you say, oh, this is going to be a companion diagnostic for any treatment, get a hormone treatment or whatever. So you have two different directions you can go in, and you're right about the tension. Yeah, it's not so much that there's a natural tension; it's simply that the locus of control switches from patient to physician in different places. Does that make sense?
Yeah, absolutely. Thank you.
So, and I think that, I want to go back to, because I think there is a lot of this tension that's out there, right? Mary read us a list of all of the requirements and regulations, and yet we're kind of actually being forced on the opposite side. Somebody was talking earlier today about, Apple has made us all want this out-of-the-box experience, right? And we're seeing this in healthcare, both from the EMRs, right? Because docs use iPhones and Facebook, and that's so easy for them, and then they dig into Epic, and it's dreadful.
Yes.
And similarly, now we've got all these regulations that you need to sign off on this and agree to that and understand this and, make sure that this is done. But that's not the experience, that we seek to have with our other consumer devices. No. So how do we as developers, as entrepreneurs, address this issue of the dichotomy of these systems?
I would partner with more advanced medical system organizations. So I mentioned one before, Sutter. I know Kaiser has an innovation center. I don't know if you've been to it. It's here in San Leandro. So basically,
I have to tell you, I work with Kaiser. Kaiser has 17 innovation centers in Northern California alone. And so a lot of times it's a little confusing, but go ahead.
Right.
Yeah, well, it's great. So innovation.
Yes.
17, where some people don't even speak the word innovation. But this particular one in San Leandro, when I visited, so it's a reproduction of a hospital environment. So when you walk in, you see where you check in, they have an ER where somebody could be operated on. They have a hospital room, and they just put in a living room to simulate an IoT care system. So when you have people at home that are trying to recover, or telemedicine technologies, they're testing it out right there. So if you have technologies that want to be tested, just apply to the Kaiser Innovation Center, and then hopefully they'll accept you so they can test it there. So those are some advanced systems. I would also look at other countries. When I started in smart fabrics, I know other countries that were already testing smart fabrics in hospitals. So usually the patient is kind of immobile. Yeah. So smart fabrics work very well when you're measuring heart rate and other biometrics. So
I want to put a pin in the other countries because that's actually something I wanted to address. And I think that's really interesting, especially for our audience here, because when I did a survey on our first day, more than half of this audience is from somewhere else. They're not Bay Area people. And so I think that this is really interesting. And while the U.S. has the largest healthcare market on the planet, it's not growing nearly as fast as China and some of these others. But before we jump there, I'd like to, Miriam, how do you actually, between the poles of, one thing that I like to say in our companies is, Hollywood knows how to sway our emotions and Las Vegas knows how to motivate us. And how do you bring those kinds of things to bear when you've got to jump through all of these hoops for regulation?
And you have a essentially consumer use product.
So my opinion is be non-apologetically, patient-centered in your design.
Yeah, right.
And then figure out how to make the regulations work for that, So a lot of people go the other way around, right? These are the regulations I need to meet, and so, okay, let's put a face or design around that. That's problematic because you got to start from what is it that the consumer really, really wants, because then the big problem with medicine is adherence, right?
Right.
So if you don't keep doing it, it's not useful. So that's my opinion. So if you start with saying that, what is it I need for the consumer to keep using this? And then saying, well, I got to figure all these other things out too. Yeah, regulations have to be made. My app has to be HIPAA compliant. There are all other things that need to happen. But if it doesn't meet that criteria to me, then you have the same Apple problem that you mentioned. So people are, if it's not used, it's useless in my opinion. So that's sort of how I think about it, and I say, okay, let's see. These are the things, as for example, women would want for breast cancer screening, and sure, there are places that we have to start with, but how do we fit everything else that's a requirement underneath that? And sometimes you have to make sacrifices, obviously, but there are things that you think is necessary and it's necessarily not in the design and the function sometimes, because especially as an engineer, a hardware engineer,
right.
I always want to do this sensor and that sensor, and I want to do this feature and that feature, and a lot of times those features necessarily don't translate into the value proposition. So I would say we have to always work backwards, say this is the value proposition and what is the minimum that we need to do to meet that at first and meet the requirements, and then of course you can add more features to it later. But that's how I've started to sort of look at it, because otherwise I think it's not going to be used and adopted very well. So.
I think that's great. So we start with the patient first. We've heard that again and again, and then this is going to lead me to my last question, and that's around these other countries, right? And how do we develop because patients are different, cultural mores are different, and
The healthcare system is different.
Yeah.
The regulatory systems are different.
Or just even the healthcare delivery system is different.
The payer systems are different.
Correct.
So as entrepreneurs, how do we consider, exporting our products to other countries, and do we often consider it? Can we consider it first?
So I see a lot of companies, at least at SK, and I can't go into a lot of details, but sometimes they have a working device, and it would take them a lot of money and a lot of time to test it here and get FDA approval. Depending on their particular medical vertical, there are health systems that are very advanced in other areas of the world that they can initially partner with to get CE certification. So I'll say the best dermatology center in an area of Europe is a great partner to go with first, so you can get the product tested there. You can save more lives early, because melanoma, if you don't catch it early, unfortunately there's a high rate of death in that particular disease. So for me, when I heard the case, okay, it'll take me 8 years to get FDA certification to do my product in the US, where they didn't know about this other dermatology center in Europe. So you need to go there, get CE, test it there, and then hopefully you can be ready to go in a year to two. So that's one example, but there are several others.
But yeah, so totally agree with what Mary just said. That's sort of more the international go-to-market strategy in terms of all the things you have to do and leveraging regional sort of advantages over there. But I think, Beth, I'll answer your question a little more broadly, which is that patients are the same the world over. Everybody wants the same thing no matter which country you live in, okay? They don't want to be sick. They don't want to have to battle chronic conditions every day of their lives. They don't want to they don't want their loved ones to be suffering all the time. So back to sort of what Marion was talking about, at some level, if you start from there, the business models may vary, but the product is the same, And so in some sense, I actually don't see that differentiation. There are tactics that are different, but strategically, it's the same thing. You have to do the same things.
Great.
Yeah, for us, especially, there's a big impact angle globally that we're thinking about, because there are places in the world that have access to no breast cancer screening, and our system, because it's automated, it provides a value that other systems cannot. So right now, one of the things you have to think about is that would be different in terms of the device is the same, but you have to think about different pricing strategies, because obviously, the way you price it here or in Europe will not work in India, for example, or it won't work in Africa. So there are a lot of different models that we're looking at. Like for example, you can partner with foundations to offer devices, offer services for free in Africa, and then you can collect the data. That data actually is really valuable, has the direct money value for your business in US, but you can't collect that data if you're charging the patients $50 or $100 or whatever per scan. So there are strategies like that to think about. Foundations are really great when you want to go to other parts of developing world, especially when you're going to places like India. The paying system is different. There's other opportunities for even paying out of pocket, because people's mindsets are different about healthcare. So people are not expected to be reimbursed necessarily for all the healthcare. So there's a lot of different strategies, like business model strategies like that. But there are places that your product could even make a bigger impact than potentially here. So that's something that we're considering. But again, it's always with startups, small businesses, a bandwidth issue too. So you kind of got to get there too. But getting a CE mark, I think, is a really good path, because it opens door for you in a lot of places in the world. So
Right.
And I think, can I do a quick follow-up on something Mary has said? And I think you were right on in terms of leveraging the international resources, or where you can get through faster. And it's been sort of a accepted wisdom in the medical device world for the last, I'd say, 5 or 6 years, that if you don't have an international strategy, you really are missing something important, especially in terms of your go-to-market or your development phase. I just want to put in a plug for our very next-door neighbor to the north. So there are a couple of regional collaboration corridors. There's one in the northeast in the Buffalo-Niagara region, and there's a great example of where they're leveraging the best of both, sort of the fluidity and the nimbleness of U.S. capital, and the sort of the stability of the medical establishment, the ability to do rapid tryouts or pilots in the Canadian system, and kind of go back and forth across the border. So there's at least one region I know of that's perfecting this binational strategy, where the early phase you're here, and then you're in Canada, and you're back in the U.S. and you're back in Canada, and you kind of go back and forth. So.
So I think this is all great, and this has been really an amazing panel, and I know that we're out of time here. I know I still have a number of questions. Our panelists should be here with us, but join me in thanking them for this. This is really great. Thank you.